So just briefly, having rolled out these patient-reported outcome measures across the NHS, what does the future hold? Well, I strongly suspect we're going to have league tables, as in education, comparisons between different centres and perhaps different surgeons of their outcomes based on these PROM scores, and perhaps performance-related remuneration for trusts. This is going to, of course, raise lots of issues. I've grouped them into procedural, statistical, political, but there's plenty of overlap there, and there's probably some ethical ones too. So there are issues about how often and when one should collect information using these PROMs, and how to go about collecting the data, and how to reach all groups based on different levels of literacy, the many different languages that are spoken in this country, level of cognitive ability. Statistical issues include the somewhat ethical ones of how to and whether to what extent to link the information with other NHS statistics that are available, how to adjust for risk, how to cope with missing data, how to compare different centres so that it's done in a fair way with a level playing field. It's complex. And then how to present the data at the end. I guess the word spin will spring to mind there. What will be the cost of all this? Probably quite a lot. And who will pay? Probably us. That's all I'm going to say. That's an introduction to the topic.
Thank you very much, Jill and Andy. We've had a short time there to have questions. So, firstly, to ask a question.
Jill, how do you cope with people's idea of pain? Because those questions always say, how much pain do you get up from the table? I mean, we all realise that some of us are very stoical, downgrade our pain, and others are, see it in a totally different way. How do you get a grip on that?
That's why these measures are used to measure change. Because everybody would probably describe the same level of pain in a slightly different way. It is subjective. But if you measure the amount of change between a person's pre-intervention situation and their post-intervention situation, if they were stoical before their intervention, they're probably stoical afterwards. They act as their own control.
That's my second question, though, because there is obviously a condition under which, when you've undergone a very painful operation, you jolly well hope that you've actually made the right choice. Do you have any problems with assessing whether, in fact, people then say, because they've gone through all this, that their pain now is very little, i.e. they look hopefully upon what they've ended up with? Do you get any feelings that, in fact, people talk up their condition rather than talk it down?
It's possible that some of that happens and we don't detect it. But we often ask a raft of other questions, such as global questions that ask compared with before your operation, how would you describe your pain now? And we ask often questions about expectations as well, additional questions that aren't part of the statistically tested questionnaire, so that we can put the scores in a context and get a bit more information.
Okay. There are often some questions which give you a handle on whether the person who's answering the questionnaire is an optimistic type of person or a pessimistic person. Sometimes. Not necessarily. No. But sometimes
There may be. I couldn't do a concrete.
No.
So and that's an interesting point.
I think I've answered some questionnaires.
There are things called like the mental health inventory, and so one paper that's come out relatively recently has looked at patients who ostensibly have got had the same operation for the same amount of pain, and whether or not they feel the operation has done them any good, maps onto their mental health status prior to the operation. So people who are relatively gloomy of disposition tend to feel that it's gone less well than people who are relatively cheerful of disposition. And there's some quite nice work that's come out on predictors of outcome based upon not just their disease status but their mental health status. And another, just quickly comment on the questions. On some of the questions that we put into the prompts are framed as well. So, for example, one of the questions is to do with do you get woken up at night by your pain? So it's making the patients, tell us about the pain, but in the context of something in particular. So it's not just tell me your level of pain. It's saying, does this pain wake you at night? And so you're trying to make it as possible as you can, but you're getting as true a picture as you can about the level of pain.
And that makes the point that we don't generally ask, if pain is likely to be an issue, then it will come out a great deal of interviews. We're unlikely to only ask one question about pain. We're likely to ask a raft of questions about pain from these different perspectives.